I'm going to introduce Ali, but and again, I apologize, but there are three of us who are really interested, plus Molly. So, do you both know Ali? So Dr. Musani was actually the head bronchoscopist for many years at National Jewish and taught a whole group of people who are still at National Jewish bronchoscopy skills. And then he left and you went to be the head of pulmonary at
Medical Wisconsin.
Yeah. Decided that the lure of the mountains was too great. Came back to really head up the bronchoscopy service at University Hospital. And I can testify to his skills since he helped me out personally with that. But what he's been able to do is because of his reputation and his really commitment to bringing bronchoscopy skills to other parts of the world, he's really made an effort to try and make sure that there are people in other parts of the world that have these skills. So he's going to talk on interventional pulmonology, essentially bronchoscopy, give us a global perspective and share with us some of the international evidence.
Great, thank you very much. Thanks for coming. Interventional pulmonology, what I thought I would do is first 5-10 minutes, I'll introduce what is interventional pulmonology, because it's still a relatively new field and not very popular, or not a lot of people are aware of what this field is. And then I'll try and go into the details of different programs and different models that we have used to train and take interventional pulmonology in different parts of the world. And then maybe in the end, a couple of, or some major challenges that we're going through. So this is a diagram my daughter and I made last year for the cover page of the book I was writing on interventional pulmonology. So I asked my daughter to draw a diagram which I asked her to show that it connects with different fields. And I said, make lots of bridges going to a little island, so it looks like interventional pulmonology is a field where all these bridges go and connect to. And she said, I was just not very scientific, and she just drew this diagram for me, and I filled up the wordings. So basically what it shows is interventional pulmonology collaborates, and it's...
Is your mic on?
I don't know if there's any mic here. Oh, there's... I don't know if this is... Yeah, there's a mic here, I think. Better? Do you hear a little better? Yes. I can speak louder. I'm sorry, I speak very... this is the mic, right?
Testing.
Okay, I'll try to speak louder.
Yeah,
So this diagram shows that interventional pulmonology is a field that overlaps with thoracic surgery, medical oncology, surgical oncology, ENT, and pulmonary medicine, and benign airway diseases, pleural diseases. So it's a very comprehensive field in the sense that we deal from diagnosing and staging cancer appropriately at an early stage, screening of lung cancer, to treating the lung cancer in a very advanced, minimally invasive ways. We work very closely with thoracic surgeons and oncologists on a daily basis. But we also work in benign diseases. We treat emphysema by placing valves in people's lung to exclude a portion of lung that is non-functional. We treat asthma by doing thermoplasty when patients have stopped responding to medicines. We go and burn the smooth muscles of their airways so their airways won't have such a powerful spasms when they go into exacerbations. So this field expands on a very big scale between different fields. So this is an example of what used to require surgery just literally 8-10 years ago, and gold standard was a surgery to go behind the breastbone and biopsy all the lymph nodes along the paratracheal and bronchial chains. Now we can go through the mouth into the lungs using this bronchoscope, which has an ultrasound transducer, and put this needle across the airway wall and sample any of these nodes. So basically, no general anesthesia required, no surgery required, no intubation required, no hospitalization required, and still we can access more lymph nodes than a surgeon can by making an incision here and going behind the breastbone, because then he or she can only go up to here. They can't suddenly make a turn to the right or left, but I can in the airway by using bronchoscope. So this is the new gold standard now. Has challenged what the gold standard was for the last 70 or 80 years. And it's cheaper, quicker, safer for patients and performer, both. So this is a sort of revolution interventional pulmonology has brought in the world. This is another thing where we go after tiny little pulmonary nodules that we find in patients as early cancers. 5 years ago, and still in 90% of the developing world, these patients require surgeries. Their pieces of lung comes out either by cutting ribs and putting your hands in the lungs, or going between the ribs and take out a small piece of lung. But now we have navigation systems which work just like the navigation systems in your car. We can go through your mouth into your lungs, and navigation will take us through the maze of the airways to the tiny nodule by electromagnetic guidance. We can biopsy it and get a diagnosis. So we can save surgeries, and our success rate is about 80 to 85% getting these nodules, especially in this day and age when we have now actively started lung cancer screening for people who are smokers and above certain age. We screen them, and as a result of that, we find more and more tiny pulmonary nodules in people's lungs. If all of them went for surgery, we would be doing about 6 million more surgeries every year in the United States, thoracic surgeries. But ironic thing is, 95% of those 6 million surgeries will find no cancer, because 95% of those nodules are benign. So this allows us to not perform surgery, go through the mouth, do a quick outpatient procedure, which is significantly cheaper, quicker, and without general anesthesia and intubation, and patients are home same day. So these are type of things that we do. This is another example of palliative surgery or avoiding surgery where patients have tight tracheal stenosis or tumor growing in their airways. We can go bronchoscopically, remove them, open up the airways. A significant number of these patients will never go to surgeon's table because they have advanced disease, they have poor prognosis. So surgeons, if you do the risk-benefit, the risk of opening up somebody's chest to remove a tiny tumor from the airway is much higher than the benefit. So then they don't get the benefit of surgery because their risk is too high. But when you compare their risk to bronchoscopy or bronchoscopic resection, the risk is minimal. So they get the benefit of resection, and they sometimes live years after that. So this has allowed patients to live much longer and better. And we have multiple studies showing that patients who undergo interventional pulmonary procedures for airway recanalization live longer and better. We have these stents that we can place in the airways to keep the airways open. So this is a quick introduction to what interventional pulmonology is. I usually give about an hour-long lecture on just introduction of pulmonary. I try to do that in 8 minutes so that you know how important this field is. But there is a difference. This is a bronchoscopy suite that we have. This is our suite at Medical College of Wisconsin. You can see the technology. And the one that we're building here is even more expensive. The budget has already exceeded $5 million. It should be ready hopefully in October for me to start working. So for us, its average is $2 to $3 million. We are doing a lot of other stuff in the suite, so it's going to cost us $5 million. This is what was in Institute of Medicine in Nepal. 1 bronchoscope, 1 broken bed, and 1 chair. And a printer which hasn't been used in a long time because they didn't have paper to put in the printer. So that's a contrast. For me to go to these places and say, hey, we have this amazing technology, why don't you guys use it? It will save you time and money and patients would love it. And they take me to their bronch suite and says, okay, what can we do here? Show us, tell us. So that's the contrast. So IP or interventional pulmonology is expensive to set up. As I mentioned, my program has already taken $5 million to start the program here. But in the long run, all our administration and division and departments know that we will save them lots and lots of money by getting patients out of the hospital, by doing procedures safe in a safer way, quicker, less blood loss, less tubes coming out of patient's chest, less ICU stay, quick recovery, and better outcomes. So everybody understands it here and they have money to invest. It also requires dedicated training and skill set, which is not available. Majority of the developing countries don't even have a single IP center or an IP specialist in the entire country. So I can go down the list of all the countries I have gone to, and there is not a single trained IP interventional pulmonologist in the whole country. So, for example, in Bangladesh, in Nepal, in Pakistan, there are maybe a couple. In Egypt, in several Eastern European countries I have gone to. Even in the United States, there are at least 15 to 20 states where there is not a single board-certified interventional pulmonologist. We are the only country in the world where we have dedicated fellowship and a board certification exam for interventional pulmonology. Not even in Europe there is a board certification for interventional pulmonology. They are trying to learn from us. We just started it in 2004. I took the first boards in 2003, which was the first board in the history of the United States. So when I trained in 2002 in interventional pulmonology, there were 4 or 5 centers in the country. Now there are about 40 fellowship programs in the country. And if we had not put tight accreditation guidelines on them, there would be 50 or 55. So we have the resources and we have the training. Now, how do we take this extremely beneficial field, which as I mentioned earlier, saves lives, is cheaper in the long run, efficient, gives you better outcomes, to other countries? And I'm not trying to be very dramatic, but without this field and skills and technologies, even to this date, and in this country where we have all the technology and everything, people die because they can't get to interventional pulmonologists. There is not a week goes by when I don't transfer patients from Wyoming or Nebraska. This Sunday I brought a patient from Wyoming who was sitting in the hospital for 4 days. She probably would have died if we had not brought her here and operated on her yesterday emergently, because she has a large tumor growing in her windpipe. And surgery and everybody has rejected her, that there's no way we can save her. So how do we take this life-saving, money-saving, time-saving technology to all the countries? And how do we train people in all different countries around the world? So my first travel to teach interventional pulmonology was Jamaica, because there was a Jamaican doctor working with us, and he said, I want to develop this in my country. And we went and trained him on his scopes. So that's one model. Teaching and training international physicians, well, that's the next model. But this is, so we brought him to our country, to University of Pennsylvania, and we trained him. So he was the only physician from the entire country of Jamaica who had the resources, who had the connections with us, and who had the money to come and spend a month or over a month and a half with us and work with us. But even then, there is a very significant limitation, which is United States laws don't allow physicians from other countries to come and treat patients here or touch patients here. You have to go through lots of hoops. They have to be USMLE passed, and then you have to go get them a local training license and malpractice insurance, and then you can train them. So as a result of all those complicated requirements, vast majority of people just come and observe here. So the training is basically observership. And these procedures these are procedures. They are not looking at x-rays and CTs or looking at pathology slides or learning how to do calculations. These are hands-on workmanship procedures. You have to get your hand dirty and practice. This is all practice, practice, practice. So we had no other option. So we brought lots of these physicians from all different countries. I started this program at the University of Pennsylvania and increased it to a very big scale, to a point where I would have 10 to 15 people every year from different parts of the world. And we trained them in interventional pulmonology. And it's really hard to screen them too. If somebody sends you a CV and application and says, I want to come and train, you don't really know what this person's skill set is if they are a senior professor of pulmonary medicine. But they may not even have done 10 bronchoscopies in last year. So you bring them, you teach them, you give them lectures, you give them material, and you show them how to do things. And then what? They go back to their country. I don't think anybody of us can watch 10 any procedures and go home and be able to do it. So there's nobody to help them hold their hands, manage their complications. And number two, they don't have resources. They come to us at Penn and University of Colorado, and they see these $200,000 and $300,000 machines, and back home they don't even have a decent bronchoscope. So we started focusing them, and we told them, focus on one technology at a time. Figure out so we did needs assessment survey. I did a whole needs assessment survey in this whole city of 13 million people in Southeast Asia. I sent the survey to hundreds of doctors, and I said, we have these 3 technologies which can help you tremendously. Which one is the most bang for your buck? And then they all said, okay, endobronchial ultrasound will be the most amazing technology for us if we can get that. It will save us millions of dollars every year and thousands of surgeries every year. So we said, okay, now send people who want to learn this technology to our centers, and we will train them. So we made a whole curriculum of lectures, one-to-one mentorship. Sometimes we made little models to have them practice. I took them to animal labs. I brought animal lungs in my wherever I could legally bring them, in my basement, and then trained them and taught them anatomy. And then we said, okay, go back and get all the resources in your hospital. Bag, borrow, steal, get the resources, and then once you are ready, we will come and work with you. And we made a whole group of people. If I couldn't go, I would ask my past fellow or my past faculty friend and say, can you go there for a week and do first 10 cases with this person? So that was one model, which is, we still are using that. And that's one of the examples. These are 4 people from different countries. I think 2 of them are from Pakistan, and I think India. They all came to me and said, we're fresh doctors, we want to learn all these technologies. And they worked with me in Milwaukee for a month. And we trained them in all these technologies for a month. Some people stayed 2 months. And then at the end of 2 months, they went back to their countries and started to do what I just mentioned in the model number 1. Second model is to develop exchange programs.
Ollie,
Yes, sir.
is anyone for these kinds of trainings using virtual reality? And I mean, is that a possible adjunct to using the animal models and doing it on?
Yeah. So that is really what we are trying to do now, and we have been, but the models are very expensive in developing countries. And working on animals is also, for instance, is very difficult and expensive in developing countries. They don't have very good animal labs. They don't have animal anesthesia, and the most importantly, they don't have animal equipment. So we can't use the same scope in human and animal. So for them to have a dedicated scope to use in animal for training is impossible. So all we can do, which, I mean, it hurts to say, is to practice on human beings, which is really what we are trying to get away from. And I'll show you a couple of my last slides. We're very forcefully trying to implement not doing that. The old model of do one, see one, do one, teach one, and then teach people literally in patients. I have tried to get the cadaveric lungs in developing countries where they have cadavers, and because if I use the same scope in a cadaveric lung, I can still clean it and use it in a human being. But if I use it in a sheep or a pig, I cannot use that in a human being ever. So models have been very expensive, and simulators are very expensive. Sometimes simulator will cost you a couple of $100,000. Models have been very expensive, but now we have come to a point where models could be bronchoscopy. Good models could be only $1,500 or something. So I've actually ordered 2 that I will carry in my suitcase to different countries to teach. So we're developing exchange programs now, which is another model. And in this model, we let the institutions decide. Now, these MOUs or memorandum of understandings are with individual institutions. For example, I went and signed a contract or MOU with university in Cairo University of Egypt. Now the university says, okay, we're such a big university and the administration is involved. So it's not just physician to physician. It's administration, their dean, and our dean has signed off on the MOU. Right now our vice chancellor and chair of medicine. As a result of that, now the institution in Cairo says, and I go and meet with them and sit down and tell them to do a needs assessment survey and guide them through all the experience I have to get certain technology and put them under a microscope and say, well, we all negotiated this for months. Now you need to invest some money and get a endobronchial ultrasound or a navigation system or a rigid bronchoscope so I can take your people and train them in my institution and then come and help them set up a whole unit here. So it requires tremendous amounts of institutional support for their physicians and for their programs. In the first model, any student, any resident, any professor could say, okay, I'm going to America to work with University of Colorado for a month. All he needed or she needed was a couple of $1,000s for flight and hotel, and that's it. Now we are talking to the deans and chancellors and telling them to put lots of money behind this. We help them get grants. international grants, industry grants, because industry has a vested interest in that too. So imagine a machine which is $200,000 by Olympus, called endobronchial ultrasound, becomes very popular and successful in China, and China ends up buying 200 machines from them. That's a huge success. 5 years ago or 6-7 years ago in India, there was not a single person using that machine. Now India has 140 machines from efforts like these. So 140 machines times $200,000 each. So Olympus made good money. But we used Olympus to incentivize people, train people, pay for these people to come to states and teach. And we did that through the institutions. We went to the large universities of India and said, Olympus will talk to you. I'm just connecting you. I have no commission in this, but talk to Olympus. Olympus talk to University of New Delhi, and I will train your people. Olympus will give you machine, and Olympus will pay for your people to come and train with me. As a result of that, we have 140 centers in India now doing endobronchial ultrasound. And you have to do it in a very clean way. Because if Olympus buys you a dinner, somebody can say, well, you have been receiving bribes from Olympus. Or if Olympus says, those people cannot come to United States for visa issues or some other issues, do you mind flying there? We'll put you in a business class and put you in a big 5-star hotel for a week. And you say, yeah, sure, sounds good. But then in the end, it doesn't look very nice. So we try to stay as clean as possible, and we connect these people. And we have done it hundreds of times. And so far, we have not been arrested or lawyers have not knocked at our doors. The other problem of institutions in the United States is when I sign, for example, MOU on behalf of University of Pennsylvania or National Jewish or some other institution, they start to say, what's in it for me? I hired you, I pay your salary, you take time out of your training, teaching, research, and work. You fly over to India or Jamaica. You're spending time there. You're bringing people from there. People are working here. How does it benefit my bottom line? So there has to be a academic reciprocity and some sense of altruism, and then some long-term gain in there. And it's funny, you have to watch for all of that. So academic excellence comes from sending our residents and our fellows to train. They don't learn novel technologies like their people come and learn novel technology and set up new centers and increase their business and have all sorts of benefits, from financial to elevating the practice of medicine. Our people just go and expand their horizons by seeing tropical diseases, working in resource-poor environment and in exotic places, and trying to, individually physicians become better by doing all that, but institution doesn't gain anything. And institutions, people who are sitting on the checkbook say, God, we have to spend your 30% of your salary and time is being wasted in those countries from their standpoint, and then we're paying for all these residents and fellows and faculty to go to these countries. We're not getting a single dime back. So that's a very common question institutions ask me when I go to them and say, can I get $50,000 from you because I have this plan of doing this? And they all look at me like, what's in it for me? And then once you involve the institutions, the logistics, the politics, the guarantees, the health insurance, all of that gets involved. So this was a pretty daunting task for us to go from very one-to-one simple, I pick up the phone and talk to the applicant in Middle East or South Africa or somewhere and say, yeah, you sound like a legit guy, you're interested, you have some experience, your CV looks good, come on over, I'll send you a letter. And they come over and work with me. Now it has to go through the whole university, international, Department of International Students and visa and all that. But if it works out well, then you really expand the possibilities. So now I can go to university in Nepal and say, not just interventional pulmonology, tell me what your surgeons need to learn. Tell me what your pediatrician needs to learn. So I'll give you an example. 9 or 10 years ago, surgeons from India came and told me that they wanted to learn VATS, video-assisted thoracoscopic surgery. According to them, there was not a single VATS surgeon in India at that time who could do VATS. This was about 10 years ago, 10 years ago. I said, I'm not a surgeon, but John Mitchell is a good friend of mine who's the head of thoracic surgery at university. Let me introduce you to them. So I introduced 2 guys from India and 1 guy from Nepal to John Mitchell. Those 2 in India now, after they worked with John for 2 or 3 months, went back, invited John to do first 20, 30 VATS with him. They do more VATS than the entire state of Colorado. So institutional collaboration expands the horizon. If somebody wants to do knee replacement or some sort of cardiac surgery or brain surgery, we can bring them, train them, and send them back. As long as our institutions have a little bit of altruism and have a bigger perspective than saying, what's in it for me? So this is Kathmandu, Nepal, where Institute of Medicine is. And this is what I did in January of this year. I went and sat down with the Associate Dean of International Affairs and Education and Director of Global Health and Global Medicine of Institute of Medicine and the principal of the medical school. And I signed the contract, and now they can send anybody they want to here for training in any specialty of internal medicine under Department of Medicine, because I represent Department of Medicine. I'm Vice Chair for Department of Medicine for Global Health. I don't have official title, but I have unofficially talked to the Chair of Surgery, and he says, we'll take anybody and send anybody from our side to train. I just don't have the money from them. The money that I have is from Department of Medicine. I can only spend my money on Department of Medicine. So we signed the contract, and we sent. So now Nepal is open. We have a website. We can send people to Nepal for training, bring people from there for training. Anybody interested, go on website, read about Nepal, read about the institute. There's a form, fill out the form, tell me which month you want to go to, and we'll arrange for it. If you belong to Department of Medicine, we will pay every single dollar of your trip. We just had 2 people go there. It's partly funded by Department of Medicine and partly by an international non-NGO grant that I have. Similarly, I signed a similar MOU with University of Cairo, where we can send our people and they can send their people. So the people from Cairo are very interested. Actually, it's funny. I had a long meeting with them talking about different specialties in medicine, and they were mostly focused on training nurses. They kept asking me, can you train our ICU nurses? Can we send a dozen ICU nurses for protocol development, running the ICU smoothly and all that? So we're working with our nursing school now to see if we can train them. This is BICOL clinic in Philippines, where our first resident, Purvi, went and spent a month in a remote little clinic and learned amazing work. She was independent. She was surrounded by all these medical students, residents. She was the most senior, second-year resident, and then she had attendings and faculty helping her. And she got to do all these fantastic procedures and central lines and other procedures and seeing patients. Residents and fellows did lots and lots of procedures. So it's a great experience, but again, why would an institution pay $4,000 or $5,000 for 1 month trip of Purvi to Nepal? That's the biggest question that comes. And the third model is deliver training courses and train local doctors in their own countries. And that has been very successful too. But again, they don't have resources. They don't have mannequins, low fidelity practice models, or high fidelity systems for training are extremely expensive. As I mentioned, they could be $150,000. University of Pennsylvania, University of Colorado doesn't even have it. University of Pennsylvania didn't have where I was before, and National Jewish didn't have. So I'm trying to rent some to do a course for our residents and fellows to teach them bronchoscopy. So simulators are very expensive. So the courses are very limited. The course I do in Pakistan or India is very different from the course I do in the United States. I do more courses in the United States than in developing countries because course there means I stand up, give a lecture, and then go straight to the patient. And we have been doing that because there's no other way. I can't wait for the expensive machines to come there. They don't have animal labs, as I mentioned earlier, and they don't have any other way than learning on patients. So we literally go and say, okay, so I try to select people who are highly experienced. And most of my patients are already bronchoscopists and interventional pulmonology or bronchoscopists for 5, 10, 15 years. And I only teach them. I don't even teach junior people because they need to learn basic bronch first. And I'll tell you in the last few slides that we have a whole plan on how to teach people basic bronchoscopy so we can start training them early and training them with the best basis for bronchoscopy. So limited resources, involvement in direct patient care, which is dangerous for us too. I don't know how many countries I have now privileged to do bronchoscopy. They are temporary, some are permanent. I go next time there, I have to go through the whole paperwork again. I don't have malpractice. Hopefully nobody will ever sue me from those countries, but if they do, I have no coverage. And my malpractice here does not cover me in any country. Actually, my institution, no matter what institution I work at, tells me you can't do procedures in other countries. So I have to tell them that no, I will. I have license to do practice in that country. And if I get into lawsuit, I will sell my house if I have to. But that's the only way. Now some countries are offering you cheap malpractice, or actually United States offer you cheap malpractice in different countries. And if I do a complicated procedure and I put a stent in somebody and then I leave after a week, who takes care of that patient? If there are complications, if a stent erodes into the blood vessels or a stent is covered with granulation. So that's another big issue that I deal with. And I am sitting on Skype all the time, seeing the bronchoscopy on the screen, saying, no, pull this wire, pull that, do this. So there's no continuity of care in that model. And then severe financial and monetary constraints. So every time I go, I'm away from work, or anybody goes away from work for weeks. Who pays for that time? And then in those countries, when I do procedures, I can't charge anybody for my procedure. So the local doctors charge, or there is no charge for using all the equipment from the hospital. So I just learned, I was in a country where I was teaching in a conference and people were watching that procedure. 600-700 people were watching that procedure on a big screen. And I was in the operating room. The physician who had scheduled those patients under his name was standing there because he was not an expert interventional. I did 5 procedures. He billed for those procedures, got cash money from the patients. So I was just flabbergasted. I'm like, really? You're making money from a person coming to your country to teach you guys procedure in a conference. You should be paying those patients. But he charged patients full amount of money and kept the money. So this is all not only a philosophical issue for me, but also a legal issue for me. So this is a course we did in Pakistan where I invited this British guy. He's actually trained just like me in Pakistan, but now he's a specialist in Burton in England to teach thoracic ultrasound. So you can see, we gave lectures, but now we're teaching on patients how to do thoracic ultrasound Fortunately, it's a non-invasive procedure. We did not do thoracentesis or put needles or anything. We just brought multiple patients from the hospital and taught people how to do ultrasound. And this was a grant. I raised money from the expatriates from that medical school. I went to them and I said, I need $20,000. So I just collected money from everybody, bought 2 thoracic ultrasound machines, asked one of my colleagues from New York and another from England, and I said, when are you guys going to Pakistan? We all are going in December. I'm like, all right, spare 2 days from your vacations, we'll teach. So I put together a whole course, and then we taught how to do ultrasound, and we bought these machines from those $20,000 that we raised. There's a company, Sonosite, that makes this, has a philanthropic arm. So I can go to them. I've done this before, and I'm doing it right now for Zimbabwe, and get refurbished machines for developing countries for about 1/4 of the price. So these machines, 2 machines for 20, actual price of 2 machines is about $100,000. And then we put it into our suitcase, my suitcase, got a special letter from the customs here that these machines are donation from Sonosite, official letter of Sonosite. So custom wouldn't bother me for smuggling. But when I got to that country, I had to sneak these machines in through the airport and security. Fortunately, I'm from Pakistan, so I had connections and I got in. I don't know what I'm going to do in Zimbabwe. I'm still working on that. But so there are some technologies you can buy, you can take, or you can have them delivered, teach, and they're so benign that you can leave them there. You know nobody's going to get hurt with it. Nobody's going to get hurt with ultrasound. It's actually going to improve their complication rates and their other issues, because right now they're doing it blindly. They're percussing chest, and wherever you feel dull, they put needle in there. Sometimes that dullness is because the lung is collapsed there. It's not because there's fluid there. So their complication rates are very high. Now they have done more than 1,200 thoracentesis with these machines in the last 2 years, and they haven't had a single pneumothorax. So their complication rates have gone dramatically down. So we taught them some other more difficult procedures too, but we told them that, don't go into thyroids yet. But this is one of the technologies which is extremely easy to learn, easy to use, and very benign. And then we handed over the machines to the 2 units. So we gave one machine to this Professor Khalid. He's the dean of the medical school and also in charge of medical ICUs. So we gave one machine to medical ICU and the other machine to surgical ICU, and we said, use it. So that's one model, but it's a really difficult model. We're trying to work on it to raise money from here, buy machines, raise money from developing countries, from people from developing countries in US and England and Europe to get money and then develop these things. Then we go to operating room and we teach procedures. So this was a place in Lahore, Pakistan, where I went to a company that makes stents, and I said, I will take all your rejected stents and slightly expired stents. And they said, we can't. We're supposed to throw it into the furnace and burn it. I'm like, give it to me. I'm responsible. It's my responsibility. I'm not going to use it in America. I'll use it in the developing countries. So they gave it to me, 40 stents, which are worth about $100,000. Each stent is about $2,500 to $3,000. Then I had a contract with Pakistan government at that time, and I said, I want to bring this as a donation, but you have to pay for shipping, which was about $3,000. We shipped it. Everything got there. Then I went there, saw about a dozen patients in the clinic, selected 5 or 6 for stents. Next day I did 5 or 6 cases in this hospital with these guys. He's a board-certified American pulmonologist, trained in America, pulmonary critical care, sleep and interventional pulmonary, but he runs a huge practice in this city. And he's the chief of pulmonary critical care at a medical university in Karachi. And we trained them in stenting and left 40 stents with them, which were used within the first year or so. But it's still scary for them not to know how to handle complications and for me not to be there to handle complications. So here we are teaching them how to do ultrasound. They didn't have ultrasound, so we, again, did the same thing. We connected them with a company in Japan, Olympus. We brought the ultrasound machine. We taught them how to do it. And then eventually, both of these guys purchased one machine each. So now there are 3 or 4 machines in that country, and they're doing 15, 20 cases a day. Each case basically means they avoid a thoracic surgery. So every day, 40 or 50 people less in that country, are requiring thoracic surgery. They're getting this done by minimally invasive way. And there are now 2 or 3 centers there who are doing it. This was my last trip this January, sitting down with one of the private universities in Karachi, talking to them how to establish interventional pulmonology program. One of my trainees from Medical College of Wisconsin went there. She's working there now because she's from Pakistan. So I leveraged her and I said, I promise you, I guarantee you, I'll teach this girl everything I know. I'll take her back to States. She's American green card or citizen. She has all the boards of certification and everything. I'll get her license in no time. You just show me the money. You put up money and a big, nice room. I will set up a nice IP suite in your hospital. So the negotiations are still going. I'm doing another course this December and meeting with their chair. Fortunately, their chair of medicine is also now from Duke. So she will understand my language. So we'll do it. It's a big private university, but very business-minded. If they don't see money, they don't do anything. This is Cairo, Egypt, where we are developing another IP program. This is funny. This is fresh pita bread. If this guy walks by you and you're hungry, you will fall on the ground because this smells so good. They bake it fresh and they supply it to all the stores where you go and take it and eat with chickpeas. This is delicious. I used to eat it every day. This is one of the largest institutions in Cairo. It's called Anschutz. Anschutz is a very big medical university. I've taught there many times. And we're really in the last steps of developing a contract with them to bring their people and send our people. Their people are more focused on doing PhD here in clinical medicine. And I don't have a pathway for them, so I'm still trying to figure out what am I going to do for them. How do I get them? So they get scholarship from their university. They spend first 1 year or 1.5 years there, come here for 6 months or a year to finalize their project and research. You become their mentor, then they go back and they do their dissertation in clinical PhD, and then you are their lifelong mentor in PhD, and you have to go there and defend with them their dissertation.
What you might want to consider, Ali, is working with Mediha, who's Egyptian, working pediatrician. She's in charge of the School of Public Health, Global Health Concentration. And if there was money in Egypt, they could bring people over for 6 months to take courses, specific research-oriented courses in the School of Public Health, and develop a joint program. So there would be some courses here and some courses there. There could even be some online courses because a lot of the School of Public Health courses are now online. We tried to do that with China and with Indonesia. So that would be a possibility. And Mediha was involved with the Chinese one. It didn't work out, but I think she would be a great person to talk to about.
Great. Yeah, I have been talking to her about other things, starting a research in another country, but this good idea. I'll talk to her about PhD program for the students of Anschutz here. That'll be great.
Their PhD programs and our MPH program are actually quite similar.
Yeah. Their PhD is not as rigorous as we have here in most of the countries. In In Spain, you can get a PhD work writing two primary manuscript on your clinical research. I think if any one of us went there, we would have 6 or 8 PhDs by now. Their PhDs are not as rigorous as ours. Oh, this is just fun. We were teaching at the university. We were strolling outside, and then my wife found all these very, very bright-looking kids. So this is my wife in the back. She just hung out with them for a few minutes and got fun pictures with them. Now, some countries are not as underdeveloped as Pakistan or Bangladesh or Nepal. Malaysia is one of them. Malaysia already has Malaysian Association of Bronchology and Interventional Pulmonology. And they asked me, and I was invited as speaker there, I don't know when, October last year. And they said, we want to develop a program for developing a lung transplant program at Putrajaya at this hospital in Sardang Hospital. So we need your help. We need your lung transplant team to come here, teach us everything, medical, surgical, and then take our people there, train them, show them how you do transplant and manage them, and then have a long-term collaboration. So that's what we're trying to do right now. Their health system is very old-fashioned health system. It's like British or even older British system where there are ministers for everything. So I had to go meet with their health minister, who's equivalent to our Secretary of Health of the United States. And this one poor guy can't even remember the names of the town, let alone name of the hospital and their programs that they need. So when I sat down with them, I said, so you guys want to develop a lung transplant program? He goes, which hospital? I'm like, you talk to your deans of the hospital, I'll talk to the dean because there's no point. I'm not a politician. I'm not here to convince you to do anything. So I basically shook hands, had tea with him, and I went to the dean. I said, you guys, so they're doing all the paperwork and all that. I may have to go there again. But once we have the whole program, we will be able to help them develop lung cancer program. So the last couple of slides, this is what you were alluding to, and I said, I'll show you a slide. The days of see one, do one, teach one, and all the 3 models that I showed you are really tough, really not very successful on a large scale. If we want to do it on a larger scale, in a very committed way, we're going to have to do what we call this new way of teaching and training. We will have to develop faculty locally in their own countries. We'll have to have some sort of a competency-based training and curriculum in their own countries. We're going to have simulation. We can't teach on poor human beings and patients, which is you don't allow your pilots to sit next to another pilot and learn how to fly. He only has a couple of 100 people in the plane. How can you train a doctor who's going to be treating thousands of patients without having a proper training, right? So, and then we're going to have partnership with them on an ongoing basis, very learner-centric. So there's a guy named Andre Colt from University of California. I was with him this weekend and the day before. He's really a good model and very philosophical person. He was the president of the American Association of Bronchology, which I'm the president now. And then he went on to become the chairman of the World Association of Bronchology. And he has really changed the World Association of Bronchology by going to these countries. He has written 5 or 6 books on just how to train and teach people in bronchoscopic techniques. He has written manuals. He has written literally step-by-step ways of training and testing people in very basic bronchoscopy, how to turn your hand left and right, how to make your thumb go down and up. It looks very simple, and sometimes we laugh that we know all this. But when you go and teach and standardize this, then you can teach the whole nations in their countries. And then now we're trying to do what we call teach the trainer courses in those countries. So we go and we start from very basics at their national meetings or national courses, and we train the 20 or 30 top bronchoscopists on very basic bronchoscopy. And then next time we go and we test them and we train them how to train other people. And then those 20 people can have these courses and train other people, hundreds of people around their country. And then we basically elevate the level of skills in people. Rather than I go and teach 10 people at one university who never go out and teach anybody else. Or rather than bringing 5 people from some hospital who could afford to come here. And there are numerous people in every country I've trained have gone back and never done anything with the training. And I just see them and I just regret in my head that why did I spend my time and money training them if they were going to come back to their countries and become administrators and do nothing. And we also need to focus on where we want to go. Right now, I go wherever I have collaboration or people are willing to invite me and pay for my trip. Or I bring people from wherever people can afford to come. But look at the disparities in healthcare needs and resources. Look at America. We have everything in the world. And look at Africa and Southeast Asia. Number of, the diseases and the burden of disease. Compare that to the workforce in global health. This is where the need is. Africa and Southeast Asia and Eastern Mediterranean. This is where we need to go and teach. But we don't get exposure to them. They don't get exposure to us. And I had so many statistics. I was going over slides last night, but I didn't want to bore you guys with all the statistics of how many millions of people have one doctor, how many millions of people have no pulmonologist, and how many millions of people have no single bronchoscope, not even a single bronchoscope. While at University of Colorado here, we have 3 navigation systems and 6 endobronchial ultrasound scopes. Each navigation system is more than $250,000. And ironically, I'm the only one who knows how to use it. Other 2 are rusting in this hospital. Because the 2 people who knew how to use it left. And people bought it. So it's very ironic. So this is now, I think, a wave forward. This is World Association of Bronchology. I'm Board of Regents of the World Association of Bronchology. And there are people from all different countries. This is our next chairperson. She's from South America. She's from Brazil. So now we're doing all these little courses, teach the trainer, elevate the level of training, skill set. But still, we're very, very limited in resources. As I mentioned, we don't even have $1,500 mannequins to teach people. So we're trying to raise money. That's our goal. Thank you very much. Appreciate it. This was a picture in Pakistan one cold morning. This is how they were going to their work. Thank you. Any questions? I'll be happy to take any questions, comments.
Dr. Musani, I was curious if the narrative of cost savings through these less invasive